So without further ado, I'd like to introduce both our fantastic speakers. So firstly, Denise Barnes, who is the lead midwife for the North Eastern Yorkshire Genomic Medicine Service Alliance, and Angela Lightfoot, who is the lead midwife for the Fetal Medicine Service at the RVI in Newcastle. Thanks. I'll hand over to you both. Are you able to share your slides, Denise? Yeah, we can see your screen there.
I'll just go up to slideshow.
Yep. Perfect. Yeah, that's great. Yeah, well done.
Okay, great. Thanks, Helen, for that introduction. So yeah, we're going to do an introduction to genomics in midwifery within this next hour. We are looking at providing 3 aims really, and we've broken it into 3 because that sort of fits within the hour and allows around 15 minutes for each topic, and then around 5 minutes at the end of each topic for any questions. And that also makes it a little bit easier if you're watching this back on iPlay or wherever else you've watched it back on, then you can obviously break it down into bite-sized chunks. So we're going to provide an overview of genomics and its relevance in maternity care. We are then going to go into a little bit more detail around genomics in the first trimester and ultrasound scan findings and testing. And then we've got another focus at the end on postnatal care and pregnancy loss. So any questions, either pop them in the chat as we go along or save them for the 5 minutes at the end of each session. A little overview for what the difference between genetics and genomics is. Hopefully the word genomics is becoming a bit more familiar, but genetics tends to be the word we're more familiar with. And genetics is the study of genes and their inheritance, whereas the term genomics now better describes the potential for testing. And genomics then studies the genome compared to just the genes. So the genome is all of our DNA, and it looks at multiple genes with a deeper interrogation using really sophisticated genomic technology. And this then allows for more personalised, predictive and preventative medicine generally in healthcare. So it really helps to build the bigger picture of healthcare. And why it's coming through now is it's already been included in our midwifery standards of proficiency, and the midwife's role in assessment, screening and care planning. We really need to be able to demonstrate knowledge and understanding not just of the anatomy and physiology, but genetics and genomics. And the technology is also advancing to be able to perform and interpret these tests. And also the cost of these tests has come down significantly, making it far more viable and accessible. We've also had a few strategies now relating to genomics in NHS care. We've most recently had the Accelerating Genomic Medicine in the NHS, which came out in October 2022. And that had 4 key themes around embedding genomics across the NHS, delivering equitable genomic testing for improved outcomes in cancer, rare, inherited and common diseases, and enabling precision medicine. It's also around enabling genomics to be at the forefront of the data and digital revolution, and also evolving the service by cutting edge science research and innovation. So genomics is also part of the vision of the NHS long-term plan and the life sciences strategy. So quite a few areas now are incorporating genomics into their strategies. We've also now got the National Genomic Test Directory, which some of you are probably familiar with. Now, this specifies which genomic tests are commissioned by NHS England, the technology by which they are available, and the patients who will be eligible to access a test. One's for rare disease and one's for cancer. I'll put the link on that slide and I can share that link afterwards as well for those that want to have a little look at that. So to be able to achieve some of the aims in these strategies, we now have, for the last few years, a genomic medicine service. And that split England into 7 areas by the laboratory hubs. And that includes the GMSA that I work for. It includes the clinical genetics or genomics services and also a clinical team. And they really are the way to harness the power of genomic technology to improve the health of the population. So that's the background of genomics in the NHS generally, but really what we want to know is, where does genomics fit into the maternity care? And I've created this image. I think a lot of the time in midwifery, we're familiar with genetics and we're familiar with a lot of the areas, but we're not always sure where genomics fits into those areas of maternity care. Now, all of these areas rely on identifying families at an increased chance of having a genetic condition, and that detection should also be as early as possible to allow for those early referrals into the perinatal genomic services for further advice, support and testing, if that's the right route. And those perinatal genomic services include your clinical genetic services or your fetal medicine services. So I'm just going to pull out a couple of areas just to go into a bit more detail on. We've got at the very top there, we've got the preconception clinics, and these are becoming more common now, especially with the advancement of maternal medicine. If there's a family history or a suspected genetic condition, we've got the opportunity to have the conversations about referral into genomic services, because some conditions may be eligible for testing. And we've also got the advancing of the pre-implantation genetic diagnosis. So before pregnancy, this form of IVF can help to identify those babies at risk of having a condition. Moving on to the booking appointment or accessing the first appointment for pregnant people. There's a lot of NHS trusts now that allow a self-referral into the maternity service, rather than the historic pathway of having to go through the GP receptionist and then the GP and getting that referral into maternity care. So the self-referral form is a great way to improve access more timely into maternity care, but really need to have a look at what that information asks of that family and that person referring themselves in. Could it be improved to empower that pregnant person to provide more relevant information to allow more timely access to perinatal genomic services? The booking appointment itself is a bit of a beast, I think. It's huge, but it does provide the opportunity to take a family history, as well as all those other millions of jobs you have to do at the booking appointment. But when a family are providing their family history, how do they know what's relevant? And we have to be so mindful when we're asking questions around family history that we're aware of that sometimes a stigma may be attached to that information that you're asking for. Sometimes with the genetic conditions, the family have seen it as a curse or something they've done wrong in their life, and that's why the family has this condition. And also for conditions known within a family and they know tests are available during the pregnancy, the woman might not actually want to officially go through that whole booking appointment if they're not going to continue a pregnancy if the baby was again affected with a condition. So it's really exploring how our services can support families to get the right information at the time that's right for them. One of the areas that I'll just touch on, and Angie's going to come on to this in her presentation, is the dating and anatomy scan. And if that picks up an unexpected scan finding, where and how do we explore if that's related to a family history? Do we sensitively explore the relationship of that family? Are they related outside of marriage? And also as midwives, if we're starting to support the screening and fetal medicine services, which a lot of areas are, how aware are we of that National Genomic Test Directory, which really clearly sets out the criteria for eligibility for levels of testing, including the whole genome sequencing or whole exome sequencing that we'll explain later. But we really have a responsibility to keep ourselves up to date to allow access for that family to these sorts of tests. We also need to be aware that some of the tests that are performed rely on a detailed phenotype, and sometimes that means having another scan in a tertiary centre to actually confirm or look for any other scan findings that will help to aid and support further testing if that's what the family want. And then just fast forwarding a little bit to after the birth, a lot of midwives are performing the NIPE examination, or the newborn and infant physical examination. And during that, you might detect something that you think could be, that is disclosed as something that runs in a family. And you have to be aware of what your pathways are to referring to the right services. And then we've also got that really sad situation of a pregnancy loss with an unknown cause. And And families often want to know what the chance of that happening is, and if you've ruled out other reasons like placental insufficiency, infection and abruption, what does that offer of genetic testing look like in your trust? And that's something that I'm really keen to explore, and I'll touch on that in a bit more detail in the third part of our presentation. So there are multiple opportunities to discuss genomics in pregnancy. And if you're not sure, really link in with your multidisciplinary team to try and find out a bit more information to support the families that you're looking after. So I'm just sharing this as an example of genomics in maternity care as a specific condition really related to maternal, fetal and paternal medicine. It's called GCK-MODY, or glucokinase maturity onset diabetes of the young. You might have started to hear this coming through. It was talked about at BMFMS recently. And really, for midwives working in antenatal clinic, how many of you have had the GTT results come back and you think either the lab have got the fasting and the 2-hour samples muddled up, or that the woman probably hasn't fasted correctly and maybe cheated a little bit? Well, actually, they could have glucokinase related fasting hyperglycemia, and it's thought around 2% of women with gestational diabetes actually have this gene change. Officially, and these are the recent conversations I've been having with our local team, it's not actually diabetes, but often misdiagnosed as either pre-existing type 1 or type 2 or gestational diabetes. A little bit of the detail is that the glucokinase is an enzyme in the pancreas, and it enables the pancreatic beta cells to accurately detect circulating blood glucose levels and adjust the insulin secretion accordingly. And that keeps the blood glucose at around 5 millimoles per litre. But a disease-causing variant in this gene encoding of the enzyme impairs its function. So that means the insulin secretion is delayed, causing a rise in that blood glucose, in the fasting blood glucose level. And that can be a rise up to about 5.5 to 8 millimoles, which is what you typically see on your fasting blood glucose on your GTT. So these women typically have hyperglycemia, fasting hyperglycemia. They often have a BMI less than 30 if white Caucasian, or less than 28 for other high-risk populations. And often they're the sort of families that women that you've been looking after that haven't responded typically to treatment. And a lot of centres and NHS trusts are now testing ad hoc when they have people that don't fit this normal criteria. However, the National Test Directory now provides eligibility criteria for screening and testing women during pregnancy, and also the option of non-invasive prenatal diagnosis, or NIPD. And because this is an autosomal dominant condition, as you can see in these diagrams, there's a 50% chance that that baby of an affected individual, whether that's the mum or the dad, will inherit the condition. So I've stolen this image and the copyright's on there. I'm not quite convinced the wording is appropriate and what we would use, but it gives you a good idea of what would happen if you have an affected mother. And if the baby inherits the same gene change, which is the baby to the left, then the baby is of average weight. But if the baby doesn't inherit the gene change, it then has to cope with those higher blood glucose levels and produces more insulin, and therefore could become a larger than average baby. In contrast, the image on the right hand side, where the father is affected with glucokinase change, then the baby with the gene change is normally grown. The baby without the gene change has to allow for the decrease in insulin levels, so that baby can be a little bit smaller than we would expect. So it has a different impact depending on which of the parents has that gene change, and often we have to then deal with the scan findings and the treatment during pregnancy without actually having any results from the NIPD. Because if you identify a mum that's affected and you look at doing an NIPD during pregnancy, the testing and turnaround times for these tests can be significant. But this is something that's going to be expanded hopefully over the next year within our reach. And if you want some more information on that, the Exeter Lab have been doing a lot more research on this, and we've got the Diabetes Genes website as well on there. So really, to summarise, the booking appointment is a unique opportunity in healthcare to review a family history, and what you do with that information is key. And really, if you're not sure, make sure you've got that multidisciplinary team to support you to get the right information to your family. And also be aware, if the initial booking appointment doesn't identify a family history or genetic red flag, that can change as the pregnancy progresses. At every routine antenatal appointment, NICE recommends that we carry out a risk assessment, and that includes asking the woman about her general health and well-being, risk factors for VTE and gestational diabetes, preeclampsia, but it also mentions to ask the woman if they have any concerns they'd like to discuss relating to parental genetic conditions, including consanguinity. So linking with the MDT is really important. We can't do this on our own as midwives, but the earlier in pregnancy the woman is referred to the perinatal genomics team, whether that's clinical genetics or fetal medicine, the more time the team have to explore the options with that family, and the more time they have to consider their options. And it's really mindful as well that genomics isn't just about performing tests, and the measure of success of genomics, especially maternity, I always feel is not just about increasing the number of tests that are performed. It's about ensuring equity of access to that personalised offer, understanding what's right for that family, and making sure they have an informed acceptance or decline of investigations either before, during or after pregnancy. And that's me.
That's great. Thanks ever so much, Denise. That's absolutely brilliant. There's no questions in the chat at the moment, but we'll just give just a few seconds just to see if anybody wants to raise their hand or if anybody wants to put anything in the chat. Just while they do, if just on that last point that you made there about the measures of success, it's fantastic to hear you kind of reflecting the importance of those, you know, informed, considered decisions, which is obviously very true to genetic counselling as well, but great to hear you reflecting that. So nobody at the moment, so just in the interest of time, I think we'll just head straight on, but if there are any questions, just pop them in the chat and we can come back to them at the end. Is that okay? Yeah, Angela, are you okay to?
Fine, yeah, I'll just try and share my screen.
Yeah, that's lovely, we can see that. Okay. Yeah, perfect.
So hello everybody, my name is Angela Lightfoot. I am the senior midwife in the fetal medicine department in Newcastle upon Tyne. My background is obviously fetal medicine, and I'm also a midwife sonographer. So I'm going to talk to you today about genomics and how that relates to the first trimester scan and onward referral to fetal medicine. So often the first point of contact with a maternity unit is the first trimester scan appointment. And this is an absolutely magical time for parents. So seeing their baby for the first time, saying hello. And this is the start of all of our genetic journeys. 23 pairs of chromosomes and the sex chromosomes coming together to make a little human. And mainly parents want to know when they first come in is there a fetal heartbeat? And yes, a little fetal heartbeat. And the next question that they ask is, how many babies are in there? Is there one baby? Is there two babies? Is there more? And actually, interestingly, researchers now think that there's actually a gene for ovarian hyperstimulation, which can possibly result in a higher prevalence of multiple pregnancies within some families. But the majority of early scans are to provide that reassurance to parents, and the majority do. The first trimester scans perform between 11 weeks and up to 14 weeks gestation, and we have about a 50% anomaly detection rate with an experienced sonographer. But primarily the purpose of the scan really is a screening tool, and that's to screen for any problems that you may see in a baby, and that's genetic conditions and sometimes a prediction of adverse outcomes, i.e. early delivery problems. So when we talk about screening for genetic conditions, we are all absolutely aware of the CT screening, which is offered to all parents, and it's entirely their decision as to whether they want to have that testing done or not. That involves the measurement at the back of the baby's neck, the nuchal translucency, plus a small sample of maternal blood that's looked at for PAP-A and free beta HCG. It has a crude detection rate of around 82.7% and a screen positive rate of around 2.8%, so a very effective screening tool. Interestingly, for those of you that aren't aware, with the maternal blood, looking at if you get an increased HCG and a lower PAP-A, that's a protein that's produced in the placenta, that can often give you a higher chance result for trisomy 21 Down syndrome. And a lower HCG and a lower PAP-A would give you a higher chance result for the other two chromosome problems, Edwards and Patau syndrome. So what happens if a parent now receives a higher chance result? Well, at one time we would just go on to offer parents invasive testing, and now there's an intermediate, so the non-invasive prenatal test. It's been introduced very recently. It's NHS funded. And just bringing in that national test directory that Denise mentioned to you before, they all have R codes, and the R code for this test is R445. That actually has a 99% detection rate for trisomy 21, and it's simply done by taking a sample of blood from mum to look at the free fetal DNA within the maternal sample. And it has a less detection rate for 13 and 18, but again, it's a screening test. What happens if we see a increased nuchal translucency, so that increased measurement at the back of the baby's neck, and that would be classed as a measurement of 3.5 millimeters or over? Well, you would go on to complete the screening pathway, but in these occasions, we would also do a referral to a fetal medicine department, a tertiary unit. Now, fetuses with increased NT are associated with a higher incidence of chromosome problems, but also some structural abnormalities such as cardiac conditions, fetal death, and actually over 150 genetic syndromes associated with an increased NT. Sometimes you don't only see an increased NT, but you can see what we call a cystic hygroma, and that's where the fluid space around the baby is actually separated into little septations, and that can not only go around the back of the baby, but can encompass right across the baby's head and across the baby's chest. It has a prevalence of around 1 in 800 pregnancies, and it is a marker for increased chance of genetic conditions and, again, cardiac conditions. But actually the most common link with this condition is a genetic condition called Turner syndrome. And I think it's worth just thinking a little bit about that, because as midwives, we are very used to talking to parents about the 3 most common chromosome problems, Down syndrome, Edwards and Patau's, but perhaps not as aware of the condition Turner syndrome. So what is it? Well, Turner syndrome has an incidence of around 1 in 2,000, and it only affects females because instead of getting 2 X chromosomes, a little girl with Turner's will have 1 X chromosome, which occurs randomly at conception. The features of Turner syndrome would be a wider neck, and little girls have a shorter stature. They have underdeveloped ovaries, which leads to infertility. They sometimes have cardiac problems and occasional learning difficulties. So what are some of the other more common conditions that we may see? Now, an abdominal wall defect, I think the most common condition that we've probably all seen or heard of is a condition called gastroschisis. So that's where the bowel herniates out of the umbilicus, and you get a free-floating sort of grape-like appearance. That fetal gastroschisis isn't associated with chromosome problems, but the other abdominal wall defect that we sometimes come across is something called a fetal exomphalus, and that's where the bowel's herniated out, but it's herniated out in a peritoneal covering, and this condition is linked with chromosome problems. So it's very important to differentiate between the two at the ultrasound scan. Got a prevalence of around 1 in 2,000 pregnancies, and it would basically supersede any screening test that had been done. And we would be talking to parents about around a 1 in 3 chance of this being a genetic cause. And it's more commonly linked with Edwards and Patau syndrome. So what else do we see? So fetal megacystis, this is another example. So fetal megacystis is exactly what it says, mega, big, cystis, bladder. It has a prevalence of around 1 in 1,500 pregnancies. And with this condition, it has a 1 in 4 chance of this being associated with a genetic condition. And again, commonly linked with 13 and 18 and other rarer conditions. It's more common in little boys with an obstruction between the inlet and the outlet of the bladder. So sometimes we can see multiple abnormalities in a little one. And with this one, we're seeing a problem with the way the head and the brain's developing, a brain abnormality. This little one's smaller than we expect it to be. It's also got this herniation, it's got this exomphalus, and not only the bowel, but some of the livers herniated out on this baby. And also, interestingly, looking at the placenta, so not just looking at the baby, but this placenta doesn't have a typical appearance at all. It's much bigger than what we'd expect it to be. And it's got this sort of molar appearance, these little sort of cystic areas inside the placenta. And when you see multiple abnormalities in a scan, that again is going to link with a higher chance of chromosome problems. With this little one sadly had triploidy, so that is a whole extra set of chromosomes, and that occurs in 1 in around 3,000 pregnancies. That can lead to miscarriage, stillbirth, and if we do get to term, then it would sadly lead to death very early on after birth. So what do we do when we see problems identified in the first trimester scan? Well, we refer these parents on to fetal medicine, and we offer prenatal invasive testing. So prenatal invasive testing would be either an amniocentesis or a chorionic villus biopsy. And in the first trimester, we're talking just about chorionic villus biopsy, which can be done from 11 weeks onwards. It's important that we are able to give our parents time and space to absorb the information that they've already been given. They've already been given a huge shock with this unexpected finding that's been seen on ultrasound scan. And then we're loading them with more information about whether they want testing or whether they don't want testing. And ultimately, it is their decision as to whether they want to have testing at all. And how would we counsel them? Well, I would talk to parents about, would a result from a genetic test actually make a difference to their pregnancy outcome? Would it be something that would act upon, or would it be for information only? And that's fine to have a test for information only, but bearing in mind that doing a test actually does carry a small chance of miscarriage. And the national figures would be 1 chance in 200. Parents also need to be made aware that not only they can be tested if they want to be in the antenatal period, but they can also have testing done after little one's born if they so wish. So for first trimester ultrasound, we would offer chorionic villus biopsy. Again, like I said, it's done from 11 weeks gestation. It's done under sterile procedure. So we use drapes, gowns, we skin prep, and we give mum some local anaesthetic because we're kind, and that's what we do. You'd introduce a needle using ultrasound guidance, and it's guided directly into the placenta, and we extract a small amount of chorionic villi into a syringe with a negative positive pressure. We do this 2 to 3 times with 1 needle until we've got enough sample. We take the needle out, we've put a dressing on the abdomen, and mum can go home relatively shortly afterwards. And we advise them to rest for around 24 hours after having the procedure done. The results. So we get a result back from the lab normally within 2 to 3 working days, and this is called your QF-PCR. So with those R numbers again, this is classed as R401. What the QF-PCR gives us is the most common chromosome problems. So we're going to be getting a result about trisomy 13, 18, 21, triploidy that we've just recently talked about, and some of the sex chromosomes, for example, Turner syndrome. In the case of a unexpected finding that's been seen on scan, we would then go on to offer further testing if this result came back with no significant findings. And that is what we call a microarray. The R number for that is R22. It generally takes around 2 to 3 weeks to get a result back. And what they're actually doing is looking at a high resolution, so it's a wide screen for copy number variants, so structural variations across the genome. And it looks at detection or deletion or duplication of or unbalanced rearrangement of the baby's chromosomes. And we're able to get that result and phone that out to the parents. So what might that result say? Well, that result might tell us that there's no significant findings. That does not mean that there isn't a genetic condition, but we haven't been able to see that on the microarray test. We might get an incidental finding. So that's a finding that's come back that's unexpected and not necessarily linked with what we're seeing on ultrasound scan. We might get an uncertain result. So that may be a variation of uncertain significance. Then you'll have heard them, they're known as VUs. We also take parental bloods when we send a microarray. So if we do get a variation of uncertain significance, we can then look to parents' bloods. Now, we all carry, for the want of a better word, some faulty genes. And if what we see in baby is reflected in either of the parents, we can see that the parents look normal, and therefore it's of little concern or no concern with the sample. So that it helps to rule in or rule out a condition. Or we might get a confirmed genetic diagnosis. So what next? So if we don't get a confirmed genetic diagnosis and we still want to investigate further, some conditions are actually eligible for further genetic testing. And one of those conditions would be an increased nuchal translucency, like we've said, a measurement of over 3.5 millimeters. There's quite a strict criteria when it comes to further testing. And we would go to our clinical genetics team and we would organise an MDT where we discuss the individual cases and whether they are eligible to go on for further tests. And we would consider that with the parents as to whether they wanted to have further genetic testing done. And what could that be? Well, that could be whole genome sequencing, so that's sequencing the whole genome. But the next test that we would think of, certainly for antenatal investigations, would be fetal exome sequencing. So what is it? So many people say to me, well, what is an exome? So I think it's worth just taking a step back. This is an introductory session and actually thinking about what an exome is and what it is that it's looking for. So if you can imagine that your genome is a big book. So you've got a big book in front of you, and that is your genetic instruction book. It's your manual. Your DNA inside the whole of your book, every single letter within that book is your DNA. Your book is separated into chapters. So every chapter is your chromosome. Within your chapter, you have your paragraphs, and every paragraph is your gene sitting within your chapter of your book. Your exons are just a few words, and I've just highlighted them within the book there. And all of your exons within your whole book are called your exome, and it makes up just 2% of your entire genome. But most of those include our instructions for normal health and development, and these are our protein coding regions. So the protein coding regions are analysed using an agreed panel. So it's an agreed panel of around 970 genes that are actually associated, known to be associated with structural abnormalities, structural anomalies that have been detected in pregnancy. We've said that there's a strict eligibility criteria, and we actually send samples of parents, so we trio test to look for any DNA differences. And I think one thing that we have to be quite aware of, and certainly one thing that I've been faced with in my line of work, is parentage. So these samples coming back and there actually being a query then relating over the parentage. which can be quite a tricky conversation to have with parents, I'm sure you can imagine. The results of prenatal exome sequencing are that the good thing is that they're rapid, and we need that information back as quickly as we can. And we get a result back normally within 21 days. And they have the potential to really increase the genetic diagnosis and to help inform decision making for our parents. So to test or not to test. So the first thing that we have to be really mindful of is, do parents really understand the level of genomic test being offered? And I think it's so important to inform parents of that. The amount of times I've rang a result out to parents and they'll say to me, so everything's fine, my baby doesn't have any problem with its genetics, it's all fine. And it doesn't mean that it's all fine at all, because we can't test for everything. And you know, some genomic tests we were not able to do as yet, and we don't understand that thoroughly as yet. Knowledge that an addition of a chromosome condition may affect the morbidity and mortality. So we're talking about a baby that already has a problem, and an addition of there being a chromosome condition could, oh, sorry about that, 2 seconds, could actually add to that morbidity and mortality for the little one. And as I've alluded to, some genetic conditions are just not yet fully understood or able to be tested for. It's really important to understand that genetic testing may not find an answer, and that can actually be really quite devastating for parents who are pinning all of their hopes on actually getting an answer. And whether the decision relating to pregnancy outcome. So just because parents have opted for a test, it's really important that we don't assume that they're going to consider ending a pregnancy. Some parents want this for information only. And even if that might mean that their baby's predicted to die during pregnancy or shortly after birth, some parents would not opt to end a pregnancy because they'd actually want to spend some time with their little ones, and we can offer comfort care or palliative care. That would be an option to them. Some parents would opt not to continue with their pregnancy also, and that would be in the knowledge that they would be fully supported in their choices by their healthcare professionals. Thank you for listening. Any questions?
Thanks ever so much, Angela. That was really, really interesting to hear, and really, really clear to understand how you laid that out. And I think for me, the reflection of both of your presentations is just how broad a role that of a midwife is, and what a fantastic job you do in all those complex scenarios, providing that really bespoke care to patients. So I do have a couple of questions myself, but I'll let other people jump in first. I'll just see if anybody's got any questions. Feel free to raise your hand if you prefer to, rather than putting it in the chat. Can't see anyone at the moment. So there's been Ruth Leary has put in a positive comment to say that she's found it really helpful, and thank you for making it so clear. That's great. So just while we are waiting for the questions to come in, one of the things you said, Denise, about you know, kind of during the booking appointment, you've obviously got so much to cover, and the importance of actually ensuring that that family history is amongst that appointment. And you mentioned about trying to make sure that, you know, it's an open conversation, that people don't feel judged with that. Can you offer your thoughts on kind of how you achieve that, how you can go back achieving it? Because obviously so my background is a genetic counsellor, we, you know, daily face issues with people, you know, struggling with, you know, kind of guilt or anxieties around genetics. So I just wondered how you kind of navigate that in the booking space.
I think it's hard. I think what we thought we knew about asking a family history and taking a booking appointment doesn't quite touch the sides. I think there's a lot of self-reflection that we sometimes need to do as midwives to actually understand why we're asking questions and the how we're asking them. I don't think there's a straightforward answer to it. I can see that Anne Radar's on the call, and I've been on a course with her that talked about exploring consanguinity, and she did a really interesting conversation with us around exploring how we thought we would feel. And can you imagine being married to your cousin. And for me, and I don't mind sharing this, I couldn't imagine it, because I felt, I don't know what I've got already in my unconscious bias around that area. So we have to be really mindful as midwives that whatever we've got with us, we're not portraying to that family. And there's some really good training on the e-learning for healthcare about exploring this in a little bit more detail. I think we need to have a further exploration and support for this as midwives, because if we get that question wrong, or we get that booking history wrong, the impact is huge. If we don't identify these families or allow them to feel supported and able to share that information with us, we're missing a huge opportunity to provide that informed offer of further referral. And I always say it's not about increasing testing. That's not what we can do in maternity. It's okay for some of the conditions, totally, but maternity, no. We need to make sure we've got that information sharing correct. So I don't have a quick answer, sorry, but
yeah.
So I'll come up with the next presentation that we've got with the pregnancy loss stuff, and we'll come on to that as well.
Okay, that sounds great. And I guess what might be good is if we could maybe circulate that e-learning for health.
Yes.
So we'll be
It's
following
on the slide of my last presentation.
Perfect. And we'll also be sending an evaluation out afterwards, so we could maybe tag it onto that email as well. So it's great to see that there's a few questions come in. So we've got, so how would you arrange testing to determine if mum has GCK MODY? So they've had a couple of scenarios where that might be relevant.
Yeah, so that's what we're looking at now, is getting the pathways in place in local hospitals. At the minute, I'm working with Leeds and York to look at what their current pathway is. There's usually a nurse specialist, clinical nurse specialist in diabetes that's got an interest in it. So it's linking in with that multidisciplinary team that supports the diabetic care, and then linking in with the Exeter, so that diabetic genes lab. They have all the test requests. They're the people that you send the samples to once they've made sure that they fit the eligibility criteria. So it's quite a simple test to do. The thing to be mindful of is at what gestation in pregnancy you're doing it. Is it going to impact on that pregnancy? And most likely, at this moment in time, it'll probably impact on the next pregnancy, because we'll have those results back in a more timely fashion to impact on the future pregnancy. So definitely linking with Exeter Lab, and then also your lead midwife, whichever area you're in. I don't know if they're in this area or not. I didn't see the chat, Helen, sorry, but you can get in touch with the lead midwife. Oh, brilliant. So yeah, email me separately and I'll share some of the work that we've done from Leeds and York already with the pathway mapping and help you get that supported in that area.
Yeah, are you happy for me to put your email in the chat,
Denise?
Yeah, okay, I'll do that when you move on to your next bit. So another question, what are the reasons behind the strict criteria for exome sequencing or whole genome sequencing? And do you imagine that in time they'll become less strict in the future?
Do you want me to take that one? I think they do. I mean, it's ever changing. So, we attend sort of many quarterly meetings with the team, and they are constantly revising and adding. And it's basically just based on that 970 conditions at the moment. But, everything's changing. The world of genetics and genomics is just moving so quickly. And the more we learn, the more we find out, there will be more then offered. But at the moment, there has to be an eligibility criteria, and that's what's funded by the NHS currently.
Yeah, and I think if I can just reflect that more generally, it's not even just midwifery that's the case for. This change that we're seeing in moving to more expanded testing is also naturally increasing demand, increasing workloads in the lab, and we too are going through a series of changes of upskilling our workforce and what have you. So at the moment, there does has to be, criteria in terms of managing the workload. Also, as Angela said, genetic testing isn't always the answer. So the more testing you do, the more uncertain answers you're going to get. So by trying to keep those criteria strict, it then helps hopefully with that interpretation work that comes afterwards and removes some of that uncertainty. So yeah, but as Angela said, we're learning so much and so rapidly that you can see that within the near future that will change. And then last question is somebody making a comment about the increasing workload for midwives, very much within the screening area, and will there be future investment for midwifery hours?
I'd love to be able to say yes. know. I feel that genomics is just adding to the maternity care. I totally understand that it's adding to the workload. Seeing the impact on the R445, this NIPT for previous trisomies, it's just an extra conversation. It isn't just an extra conversation. It involves a lot of liaising, getting the right pathways in place, giving that right support to the family, not just at that point of testing, it's afterwards, future pregnancies. So being able to locally measure the impact is really, I find, impactful. I've come from a matron post where, as a midwife working on the shop floor, you need to know what that impact is. You need that evidence. So if you can capture the impact of this change to then support why you need extra hours or extra midwifery time, that's often quite a good tool to do locally. The national stuff is bigger than me and Angie, sadly, but you know, our role as part of the regional lead is that we link in with a national perspective to try and have your voice. So if you link in with your regional lead midwife, if that's me, let us know and we can feed that back to the national team, including the lab, because the lab generate these tests and create these tests, which is fabulous, but there's a gap between the lab and the clinician trying to do that test, and we're really trying to improve that to make sure the right information is coming out before we start the testing. So it's work in progress, but I totally understand that it's impacting on the midwifery workload.
Great, thank you. That's the end of the. Sorry, I muted as I said that. Yeah, that's the end of the question. Sorry, if you want to move to the third section, that'd be great. Thanks, Denise. We've got just short of 15 minutes.
I can do that, no problem.
Brilliant, thank you.
Can you share? Oh, I need to go to the slideshow again, don't I?
Yeah, we can see that. Yeah,
perfect. Okay. So this area is more sensitive sometimes because we're talking not just about postnatal care, but pregnancy loss and genomics. And really passionate that genomics in maternity care isn't just about prenatal invasive testing. That's my background, that's Angie's background. However, some families opt for testing after the baby's born, and some have a apparently routine pregnancy, no scan findings, no scan concerns, and then experience the horrendous pain of losing a baby. And that often comes with a whole host of emotions, which include trying to work out why it's happened. Some have had no scan findings and then have hope that the scan is wrong or the diagnosis is wrong. Some have an instinct that something isn't quite right. And for some, this is something that's happened completely unexpected. And they want to know if it's something they did or could have done, and does it have a chance of happening again? One of the leaflets, or patient information leaflets, the RCOG have states that around 6% of stillborn babies have a chromosome abnormality. That's 1 in 17 of stillborn babies. So this is really where an area of genomics can help to support. This statement from the RCM describes how that knowing a gene alteration is not inherited provides peace of mind. But on the flip side of that, if it is inherited, it can allow for predictive, preventive and personalised care. We talked about the offer of pre-implantation genetic diagnosis, but even just to the right place of birth for their baby, the impact of genomics is really significant. I'm just going to share a patient story with you briefly. This is a story about Eve, and probably quite a common story that you've seen in your services. Eve was referred to the fetal medicine unit at 16 weeks of her pregnancy. She'd had previous recurrent miscarriages, and because of that fulfilled the eligibility criteria for postnatal testing, and her postnatal testing result came back as having trisomy 18. But this result wasn't received until she was 16 weeks pregnant. And so the obstetric consultant lead received this information and referred her straight to the fetal medicine team to go through what her options were. Now, this was prior to the introduction of the NIPT, the R445 for previous trisomies. And this, unfortunately for Eve, she not only had not had the fact that she was awaiting test results detected at her booking appointment. She also then was unable to get a nuchal translucency measurement at her dating scan, and so was not able to have combined screening. So to work out the chance of this baby having Edwards syndrome, we hadn't been able to do that for her. So she was left in a real conundrum as to what to do with a pregnancy. It does show that there's is a good example of testing being offered following a recurrent miscarriage, and we now have the support of the NIPT to be able to work out the chance of her in a future pregnancy having trisomy 18. But this sometimes happens in pregnancy where the information that we want at the booking appointment is not always shared. But if we'd have known, we could have tried to expedite that result to get a result faster for her with her being currently pregnant. Some people have a higher chance of there being a genetic reason for their pregnancy loss, and it's always worth exploring some of these areas as part of your care, looking at her age, looking at the age of the father. Is there any significant family history of either recurrent miscarriages or fetal anomalies? Are they in a close relative marriage? Have they had a known suspected fetal anomaly? All these things can help to add to the picture, so it's really worth exploring this information. We've gone through some of the tests that can be performed in Angie's presentation, and they are very similar in postnatal testing following a pregnancy loss or like a miscarriage or stillbirth. And it's also been really mindful of what's not going to be tested. We talked about the QF-PCR, which is the common aneuploidy testing, or aneuploidy just means an unusual number of chromosomes, like your trisomies. Trisomy 21 is Down syndrome, monosomy X is Turner syndrome. And we also include microarray. So often following a pregnancy loss, if they fulfill the eligibility criteria, a microarray, so looking at extra bits and missing bits of chromosomes, plus the count of the chromosomes is done for these families. And I think part of the challenge that I've noticed with trying to introduce genomics and talk about genomics in this area of maternity care is that as midwives, we assume that this is already being done. So we're already doing genetic testing. And so that means we're looking at all of the DNA when we weren't aware that actually it's only to a certain level and for an eligible population. And also when we're talking about this, we need to consider the consent process for genetic testing. So I know in my experience as a midwife, when I used to work on delivery suite, and this is talking a little while ago now, but the consent process involved ticking a box on the bereavement checklist. That was it. There was no written consent, and that written consent is really best practice for genetic testing, whether that's antenatal or postnatal. The quality of that consent process is paramount. Again, not the rate of uptake of tests. Have they made an informed acceptance or decline of that testing? And we can only do that if we, as midwives, know what tests we're offering and the limits of those tests, and also understand the impact of those potential results. We've also got to consider the turnaround times. Turnaround times antenatally are a lot faster than postnatally. You've got a time limit really for decision making during pregnancy. However, after a pregnancy loss, that urgency is not there in the lab. They do treat them, relatively as quickly as they can, but it's not as urgent as an antenatal test. And often we're seeing that families are pregnant again without getting the results. So really be mindful if there's outstanding results to contact and liaise with your lab team to try and expedite that result. The other thing that's coming more and more aware of is the post-mortem. And I think my experience of consenting for tests like this, I probably relate to giving a HIV diagnosis, which probably sounds a little bit obscure. But when I've given a few HIV diagnoses to women during pregnancy, rather than telling them initially they're HIV positive, I told them about the condition, what it was like, how it would impact them, and that taking medication would significantly change their life. And then I said that they were HIV positive. And I think that's similar to if you say we'd like to offer you a post-mortem on your baby. We've all seen images of, police documentaries and crime things of what a post-mortem means, and the horrible mortuaries and the cold clinical areas. And I think that really provides a block to families to be able to consider impartially a post-mortem. So I know a lot of trusts are looking at the consent process for post-mortem, so it is really worth exploring our language that we use to gain consent and informed decline for these tests. This is just a summary of the common tests that are offered following a pregnancy loss, miscarriage or stillbirth. These only include QF-PCR and microarray. Now, there are other tests that can do whole exome sequencing or whole genome sequencing. This is probably not the level for the introduction level that we're doing today, but if you want more information, that will all be in the National Test Directory. And these tests often overlap. The main thing to consider is that these tests can't be initiated like the whole exome or whole genome sequencing in isolation. So you as a midwife, it's really unlikely you could instigate a test like that. You need to do it in collaboration with your local clinical genetics team, fetal medicine team or perinatal genomics team. And they need to find out about these eligible families from you. So having that working relationship with your multidisciplinary team, so you can ask the question, would this family be eligible? And that'll expand your knowledge and also the access of the families that you're looking after. A little bit of feedback from our labs. This is taken from some of the comms when they sent out an update regarding the criteria for testing. The completion of the test request form is really struggling, and they're struggling to turn around the results in a timely manner because the information on that form is incomplete. They need the test indication code, they need the gestation, they need the details of the congenital anomalies, if there's a known reason for the third trimester loss, all of that information they need. It looks really complicated, and as midwives and clinicians, we are historically quite poor at completing a form accurately. But when we consider the impact of not doing that is impacting on that result getting back to the family, we really need to be more conscious about how we're completing these forms. Ideally, they would be online, it would be a tick box and we could fill it in completely, and then that would sort of allow us to see where that sample was in the system and getting the result back to us. We're not there yet. So in the interim, this is a little plea from the lab, is can we try and improve the information we provide on that test request form to improve the results getting back to the families. And then just a little bit of an update on some research that's happening. This is again linked to the postnatal side of things. This is a research study that's happening across England, run by Genomics England, not to replace the newborn blood spot. This is really key, it's not replacing that. This is a research study looking at the feasibility of taking the genome from cord blood of 100,000 babies, that's the aim, across England, to be able to report on over 200 conditions, of which early diagnosis will allow for early and sometimes life-saving treatment. So the impact of this study is going to be huge. In the northeastern Yorkshire, we have one trust looking at signing up and moving forward with the study, but in other areas of England this has already started, so we're looking forward to hearing how this is being rolled out. This is not only around sequencing the genome and storing it and how that impacts on the future health of the babies and as they grow up and mature over their lifetime, but also the consent process. So how familiar and able are we as midwives? Are we the right people to consent for this study? There's lots of things being explored, so watch this space. If you see this coming through your trust, it's a really exciting thing to be involved with, but it doesn't replace the newborn blood spot. So again, what can we do to help is the regular genetic risk assessments. These are all the things we've talked about already. Following a pregnancy loss, there could be a genetic or a genomic reason, so link with your multidisciplinary team, and the PMRT review tool is quite a good place for this to be captured, or your perinatal mortality review tool. Often genetic testing is identified as being performed during this review tool, making sure that your eligible population or your eligible families are actually being offered, and documenting that offer and informed acceptance or decline is really key to keeping that documentation clear, especially for future pregnancies. The earlier in pregnancy the woman is referred to the perinatal genomics team, whether that's clinical genetics or fetal medicine, gives the team more time to explore the options, not just obviously in that pregnancy that they may have lost, but in the future pregnancies. And as we said before, genomics is not just about performing tests, it's about ensuring the access and the personalised offer, either before, during or after pregnancy. So I've just got some links on there which I'll share with you as well. One's around the generation study, one's around the test directory. We've also got some education on there from Genomics education programme, and we've also got Genotes, which I'm not sure many people are aware of, but Genotes is a just-in-time resource where it says fetal and women's health, and there are lots of different clinical situations where if you're faced with a family that maybe disclose they have a family history of Duchenne's muscular dystrophy, say, it gives you the clinical pathway, what to follow to allow their families to get access to support and testing.
That's great. Thanks so much, Denise. That's brilliant. And those links will make sure that we put in the email that we circulate afterwards with that evaluation form. So I'm aware that we're dead on at 1 o'clock. So for those of you that need to leave, that's fine. The recording will be available after the session. So if you do have a question you want to ask and haven't got time to ask it, then feel free just to put it in the chat and we can record it and send it round shortly. For those of you that are leaving, just to let you know that we have a certificate of attendance available by filling out a short evaluation. You can either do that now following the link that I've just put in the chat, or alternatively you can simply do that when we send it round on an email. It's only a 5-minute survey, so it shouldn't take you too long. That's great. And if you could just move to the next slide, we should have a slide for our June Lunch and Learn. So this is for family cancer, primary care management scenarios. So if you're linked in with any GPs that you think might be relevant to, then please feel free to signpost to those. That's in a couple of weeks' time on the 13th of June. So thanks ever so much again to our speakers. I think there was a question that came in about Angela's presentation. So it was talking about the fact that locally amnios are offered but not CVS, because the CVSs are referred out when counselling.
Helen, I've just replied to that. I've just put a message in the chat. I've just replied, yeah. So turnaround times for testing are the same. So essentially it's only the sample that is different, but the actual testing procedures are the same. So there shouldn't be any delay with that. I think I just said that if you were to get a CPM, so a confirmed placental mosaic result, then it would require a little bit longer because they would need to go on to culture the sample a bit longer. But the turnaround times themselves are the same.
Yeah, that's great. Lots of positive comments that I'll leave you to read yourself about how helpful people have found it, which is great. So those positive comments are fantastic. If you can just pop those again in the evaluation, then that's really helpful because it just helps us work out whether we're hitting the mark with these Lunch and Learn series, and just helps us to demonstrate that we hopefully are trying to support you all in the best way that we can. Denise's email also went in the chat for anyone that wanted to reach out. And there is also another email in the chat from one of the Southern Services. Sorry, I can't remember. For North Thames it is, yeah. So for North Thames there's also an email there from Tina. And for those with a special interest in genomics, Denise, there's your MIGS group as well, isn't there, if anybody wants to reach out to discuss that?
Yes, definitely. Yeah, everyone's welcome.
Yeah. Okay. All right. Well, thanks ever so much, everybody, for attending.